Welcome back to Inside the Wellspace, the podcast where we step into bold, nuanced conversations about health, healing, and what it truly means to thrive. Today, we have with us a trailblazer in women's health, Dr. Creatura. She's a mother, a daughter, a sister, a clinician, an educator, and an unapologetic advocate for reproductive freedom, menopause awareness, and sexual health without shame. Dr. Creatura is board certified, who's been in private practice in New York City for over 3 decades. She's also a certified menopause practitioner with the North American Menopause Society and the first full-time New York City-based gynecologist to become a fellow in female sexual medicine through the International Society for the Study of Women's Sexual Health. Her work bridges the clinical and the deeply personal, addressing everything from adolescent gynecology and vulvar disorders to sexual rehabilitation for cancer survivors and patients with complex medical needs. She collaborates closely with sex therapists, advocates for policy change, and educates with humor, humanity, and a fierce belief in women's autonomy. She's also a proud graduate of Barnard College, Harvard Medical School, and the Physicians for Reproductive Health Leadership Training Academy. And today, she's sharing her insights on everything from desire and discomfort to how we can reframe menopause and destigmatize pleasure at every stage of life. So let's step inside the Wellspace with Dr. Creatura. Wow, we are so lucky to be talking with you today, known for your expertise in gynecology, menopause, sexual medicine. And what I'm going to say is we all need her. We need her. One of the things that you said to me when we started talking was you said, we want women to get what they need. It's a cultural priority, right?
Indeed. And thank you for pointing that out, because I do feel that it's a great privilege to be able to speak to you about misinformation and how misinformation pervades almost all of women's sexual health.
It's true, isn't it? Oh my God, there's so much to talk about. My head is exploding because when you say that, it goes in 5 different directions.
Right. But
however,
connected.
I know. So we've got to reel ourselves in because we could be here for hours and then we'll get in trouble. Can we start with, can you just ground us in what exactly is both perimenopause and menopause? Like, what is that?
Yeah. Well, I think that really we're doing a disservice when we try to separate them into 2 different phenomena. It's really a continuum of neuroendocrine aging.
Got it.
And it's a more streamlined way to think about it, because I think we actually have made a mistake in trying to distinguish between these things.
Okay.
As we all age, things change.
Totally.
And menopause is really just another neuroendocrine transformation, just like puberty and pregnancy, that unfortunately most physicians, most caregivers don't get any education in. And I think you might know why, right?
Why is that, doctor?
Because it doesn't happen to men. So everything that is not male gets siloed into the practice of obstetrics and gynecology.
Right.
And that's a lot for us to manage.
Well, it feels like the real sort of like GP that we're talking about is your gynecologist, not your
For women.
For women,
Yes.
right? For us.
And to be fair, lots of general practice and family practice docs actually do provide comprehensive medical care for women at all stages of life.
Right.
But it's a big order. It's a lot to know about.
Yeah.
And I think when women are frustrated that their physicians are not educated about menopause, I can identify with that frustration, because I think that negation of all women's experiences is pervasive throughout medicine and the culture. I'm frustrated too.
Yeah.
But I think we have to get empowered as women to really get educated about these processes, so that when we go to our physicians and our caregivers, we actually have some information to share with them. We're ready to
to talk and say okay, this is what I know about myself, right? I mean, it's it's true. I mean, look, I have an amazing doctor who's my regular doctor, not my gynecologist, and I love her, but I wasn't really paying attention, to be honest with you. I just wasn't paying attention when I was going through perimenopause or menopause. This wasn't talked about, I guess, right?
Right.
It's not talked about.
Well, we don't talk about a lot of things that impact women, because if we talked about it, we'd be giving them information, and if they had information, they might have power.
Well, I'm with you on that. And the point and purpose of Inside the Wellspace is to gain power for yourself, to just know this, right? I need to know one thing aside from the many other things I'm responsible for, like children and marriages and jobs, yada, yada. I need to know this, right?
You need medically accurate information about your body.
Thank you. So going back to the peri and menopause stuff.
Yeah.
Tell us what When does it start? What does it look like? How do we know? Who do we talk to?
I'm going to talk about it the way I like to talk about it, which is going to be different from the standard text and hopefully different from the standard talk that you might have on menopause.
Good.
Because I really think that we are neglecting what happens to women as they age by defining something as peri or post or menopause, which is, very arbitrarily defined as the cessation of menstruation. It's really a neuroendocrine process that occurs over at least a decade, probably more.
So it's like not like something's ending. It's like something's beginning, actually.
It's changing.
Right?
Yes. It's a change.
Right.
And yes, you could say it's the beginning of a certain phase of one's life.
Right.
But what I really want people to understand is that this is not just a declination of your reproductive capabilities.
Right.
It's a transformation of how your brain works and how your brain is affected by your physiology. Right. So if we're talking about perimenopause, I think we really should call it andropause, because the decline in androgens that begins more than a decade before the cessation of menses is correlated with a lot of the symptomatology that women report.
Okay, wait. Let's stop for a second there, because androgens. So here's what we know about. We know about estrogen. Ovaries, our little ovaries, make estrogen, progesterone.
And androgens.
Well, who knows that?
Well, I don't know. Why don't people know that?
I don't know. What's an androgen?
Don't gender hormones. All people of all genders have all these hormones.
They do. Do we? And do our ovaries make testosterone as well?
Of course.
Okay. And androgens.
Of course.
So,
testosterone is an androgen.
Oh, it is?
Yeah. So all of these are steroid hormones, and all of these steroid hormones have neurologic effects. They also have effects throughout the body.
Okay.
So that's what I mean when I say a neuroendocrine transition.
Yes.
Because testosterone doesn't just control the production of sperm. Testosterone maybe controls even the production of eggs, although that's under-investigated. But all of these hormones...
Let's just know that it's all under-investigated.
There's a huge gender gap of all research, right?
Yes.
And it's vast,
yes.
Right? In sexual medicine, we talk about the gender gap of orgasm or the orgasm gap, but I would like to just generalize that to say there's a gender gap of everything.
When it comes to
understanding that andropause or a decline in androgens may be responsible for most of the symptoms that women experience in perimenopause is really important.
Yeah.
And it's really under-recognized.
It's under-recognized. So I just jotted down some symptoms because I listened to, ever since we started talking, of course, like I start listening to books just to learn stuff. It was a common denominator is missing estrogen, but there's more to it.
Yes.
Obvi.
Oh, and estrogen's important.
It's huge. But wait, so here are the things, some of the issues that I read that we suffer. CFS, I don't know what that is. Crawling skin, dental issues, depression, dry eyes, dry skin, frozen shoulder, which is a thing, who knew? UTI infections, high cholesterol, irritable bowel syndrome, irritability in general, itchy skin, migraines, mood swings, muscle loss, sleep apnea, and other sleep stuff. Tinnitus, which a friend of mine had and couldn't get rid of. TMJ, hair, loss, whiskers, whatever, weight gain, etc. I mean,
every one of those things that you mentioned is impacted by a declination of hormones, right? A decline in hormones.
So it's like
or
a slow
change in the ratio of hormones.
As you're starting to lose the hormones of all sorts.
Right.
These things start happening.
Absolutely. And they're not confined to one part of the body, as you made eminently clear.
Right.
But this is what leads women to seek help from their physicians. And they may go to one physician for joint pain and another for their mood changes and another for their sleep disorder, another for their heart palpitations and another because their bone mass is down.
Right.
And they might get 5 different drugs instead of actually having somebody synthesize everything and understand, oh, this is actually the neuroendocrine transition that we're discussing, right? Actually, what's happening here? There's a drop in androgens, a drop in estrogen, and this is why my patient doesn't feel well.
Right.
Let's try to give her one thing, one natural thing that her body used to make, like we do with the rest of the endocrine system. But somehow we don't do when women go through this natural process, which every single woman experiences.
Wait,
this is not novel. It's not a rare disease.
No, it's like mind-boggling when you think about it that way, right? When you think,
it's so obvious that it's true, right?
Yeah, I got another stat if I can find it, right? Oh, yeah. So the stat, 1/3 of American women are experiencing some stage of menopause right now. 1/3. And there are, by the way, 170 million women in America. That's just like a little tidbit of information. So, and the other one was 51% of women will experience menopause if they live long enough to experience it, right?
Yeah, it's probably
more than that,
more,
right? I saw that. I was like, I don't know.
I mean, I'm often talking to a woman like you,
Yeah.
and I'll say, when they ask me, why all of a sudden do we understand menopause? And I'll point out that if you and I were alive 125 years ago, one of us would have died in childbirth. We wouldn't have lived long enough to experience menopause.
Yeah.
We would have been perpetually pregnant because it wouldn't have had the ability to decide when to be pregnant.
Right.
And our pregnancy care was so miserable because
Right.
we didn't have antibiotics and blood transfusions or any sort of modern medical care.
Right.
That we would actually be worn out by the repetitive tyranny of reproduction.
Oh my God, the mind-bogglingness
Right?
of all of that is true. And
So
that
now
wasn't
we
that long ago.
No, because it was very briefly that it was really during our era that women acquired the ability through medicine, through endocrinology, my favorite topic,
Is it?
to actually regulate your own reproductive capacity.
Huh.
Right?
Yeah.
If you had access to hormones that could actually keep you from ovulating incessantly, you could live longer.
You could live longer.
Mm-hmm.
Well,
and more safely.
And more so when I was, my whole peri and menopause journey was like, I don't even know. I mentioned this to you. I was going through a divorce at the time, so I figured everything that was happening to me was that.
Right.
And I went to see my gynecologist at the time, and I said, I just feel bad all the time. Like I feel so bad. And I also had sweats then. I was in my 40s, so it was peri. It wasn't menopause. Oh, it was part of the whole journey.
It's part of the whole thing.
He prescribed me an antidepressant.
Right.
Didn't even ask, didn't suggest. Like, it should be the umbrella that every doctor talking to a woman.
Right?
Yes.
Like, it's so clear that there is a decline in her hormones.
Right.
That if you actually took a good history, that you could give a trial of hormone therapy.
Why not?
Right? Because it not only would help with the feeling of badness that you describe, the fatigue, the night sweats, the sleep, the joint pain, the energy, not to mention sexual desire.
Zero.
Not to mention preserving your health, protecting your bones, protecting your cardiovascular health, protecting your brain.
Oh, God, all of it. See, this is so massively important as I've been researching and reading.
Yeah.
And the decline is real in all of these things. You can feel it. None of us are making it up.
Oh, what that theme of somehow we're making it up, that somehow our symptoms aren't real, is pervasive throughout not just medicine, but the entire culture.
Yeah.
The concept that women are hysterical,
it makes
right?
me crazy.
Or that women are just anxious, right? They don't really have high blood pressure. They're just anxious
And
because they're wearing a white coat.
And then we drop dead of heart attacks.
Exactly.
That's what kills us, by the way.
We wonder, why do women actually have more cardiovascular mortality when we decline to actually acknowledge that they're having chest pain?
I know, right? It's crazy.
Baffling.
All right, ladies, we need to get a grip here.
Yeah.
We got to figure this.
Like,
no, seriously, we need to get a grip because we need to know this stuff, right? Again, the head going in a million different directions because I'm thinking about let's actually talk a little bit more about the hormone replacement stuff because when I was, I don't know, maybe 50, my doctor, or maybe 52 even, put me on the pill as like hormone replacement therapy, basically.
All right.
So that
birth control pill.
A birth control pill. I'd never done it before.
Yeah. So oral contraceptives, also known as birth control pills, are a type of hormone therapy.
Okay, good. So I feel good.
And so that's not a terrible choice.
Right.
And certainly if I'm seeing a woman who's still cycling, meaning she still might be vulnerable to pregnancy and doesn't want to be pregnant, if she has sperm in her life, I want to protect her from that sperm.
Yep.
So I might offer her oral contraceptives, which are a stronger form of hormone therapy than what I might offer someone who hasn't had a menses for a year or two who's starting to suffer.
Really?
Right? Because it's a different format. It's a different delivery system. Right? I've said to you, all hormones aren't the same.
Yeah.
And unfortunately, even in the medical literature, they're often generalized as if hormones were one thing.
They are,
right?
very much so.
And they're not, right?
Isn't that fascinating?
So when we're talking about hormones, we're talking about groups of drugs or groups of interventions, just like we would if we're talking about antibiotics or chemotherapy, right? There's nuances.
Specific.
So you need to be an expert to know how to use them properly. So oral contraceptives isn't a bad choice.
Right.
It's a little more potent than many women need, but it does protect you from pregnancy, which is really important.
Right.
And you also should know that oral contraceptives have different metabolic effects than a transdermal or through the skin delivery system for hormones.
Which is like patches and creams.
Exactly.
That's transdermal stuff.
Exactly.
Okay.
Right. Thank you.
Yeah. And then, so what does that mean? What does it mean?
Well, it can have different implications. And again, protecting you from undesired pregnancy is key. It's ever more important because you may not be able to control your reproduction should you have an unplanned pregnancy.
Right.
So that's very important.
Yep.
But transdermal delivery of hormones is actually metabolically different and probably more favorable for almost everyone.
Why?
Right? Because when you're taking an oral form of any estrogen, and there's a whole bunch of them, we won't go into all the details of that, but taking it orally causes you to metabolize the hormone differently. It passes through your liver or through your gastrointestinal tract first, so that it actually promotes the development of certain substances from your liver, which impact how the hormones can work in your body, which means you may have a higher risk of blood clotting, and a small risk, right? I mean, nowhere near the risk of blood clotting that you experience if you're pregnant. Right? So we have to keep those risks in perspective. You have an increased risk of blood clotting with an oral form of hormones than you do with a transdermal. The way that the liver metabolizes these hormones also has an impact on the bioavailability of some of these hormones. And what that means is I could give you a medicine, but it might not be available to the tissues I'm trying to target if there is a protein produced by your liver that blocks its efficacy. Does that make sense?
Yeah, that's fascinating. But then how do you know what's right to give somebody?
You don't always know if you don't actually read the literature and use your expertise and talk to the patient about what she needs.
Right.
So, for instance, I might have a patient at 49 who's on oral contraceptives who has a very, very high protein made by her liver that binds all of her testosterone. That might be contributing to an absent libido or poor sexual functioning or poor sleep or even tremendous fatigue or even brain fog.
How do you find out, though?
Well, you've got to talk to your patient because everybody doesn't respond the same way. Right.
So so you give, because I'm thinking about for everyone who's thinking like, okay, I'm in my 40s or even 30s thinking about it, or maybe even starting to feel these things.
Right.
Okay. How do I know? What do I take? That kind of thing.
It's so personal and it's so difficult to generalize about hormones. Sometimes people say, okay, are you for or against hormone therapy?
Right. I know. I get that all the time.
Right?
Yes. I'm like, I don't know.
Okay, I'm for hormone therapy, but I'm for individualized, nuanced medical care.
Right.
Right? It's
In
not
general.
like I would say to anybody that there's one thing everyone should do.
Right.
But I would say that for the general population, it's so important to endorse that oral contraceptive therapy is associated with a decrease in all-cause mortality, which means, I'm going to spell this out.
Yeah.
If you are on oral contraceptives in your reproductive years, you are less likely to die than if you don't. That's important. Because it protects you from pregnancy. It protects you from ovarian and uterine cancer. It protects you from ruptured ovarian cysts. It protects you from benign cysts. It protects you from going to the operating room. It protects you from having a tubal pregnancy. Nice. There are so many health benefits.
Right. Doesn't it help with heart disease too?
Maybe.
Estrogen, right?
Yes.
I think.
Well, all estrogen. But I was about to say this is on oral contraceptives only.
Okay.
And then the corollary is postmenopausally. If you're on hormone therapy postmenopausally, you have a decrease in all-cause mortality. Sound familiar?
Wait, we need a sidebar on that because I'm postmenopausal and I'm on nothing. Yeah. And I'm like, I don't know if and okay, so this is just total tangential. I'm taking because I had breast cancer that was estrogen positive. Yep. All good, stage 1, no spread, blah, blah. But now I've got to take this pill that suppresses.
Blocker.
I know. And now I'm like, is that good or not good?
Well,
I don't know.
The oncology world needs to do some quantitative analysis, not just are you going to have a recurrence of your breast cancer? Because they've done that. Right?
Yeah.
The oncology world sees you as a person with breast cancer.
Right.
And they don't want you to get breast cancer again.
Right.
And they've become really good at decreasing that.
Totally.
Right? What they're not good at is seeing you as as an entire person who has a future, who has a life, who has a brain, bones, sexuality, all of which needs protection.
Yes.
And what I haven't seen is a good quantitative analysis of the harm being caused by that adjuvant therapy and the additional, not just the deaths, but the additional diminution in quality of life that those poor patients experience.
It's on my mind now. Yes. And I'm actually really excited about this endeavor around the well space because it's forcing me to really pay attention.
Right.
To, okay, listen, I'm thankful and appreciative, obviously, of everything that the treatment I've gotten, et cetera. However, this thing about hormones and HRT and like the different types of estrogen, all of it, as an individual, this is exactly what we're talking about.
Well, we have to look at the whole picture.
Right.
And I often tell patients that of course, I don't want them to get breast cancer again. And this is nuanced, right? This depends upon so many different aspects of the patient's disease and what her other disease risks are and how much suffering she's having.
Yes.
But really, there's like no corollary for men where we would take away all of their hormones and just tell them to suffer and be grateful that they don't have cancer anymore.
Nope.
We use the same that same ideology for women whenever they have terrible pregnancy outcomes or even just like lousy effects on their health because of pregnancy, and everyone says, "Aren't you just glad you had a healthy baby?" Isn't that really the point of view?
My vagina is wrecked.
You're a mother.
I mean,
right?
I feel horrible.
So what if you pee every time you laugh? So what if you'll never have sex again?
You have children.
You know, so what if you damaged your heart because you had a heart disease as a result of your pregnancy?
Right.
You have children.
Oh my God.
So what if you lose your brain matter?
Oh my God.
We wouldn't say things like that to people who didn't get pregnant.
I know. And it's the guys.
Well,
I don't want to, that's horrible for me to say. I don't know,
but it's true, because you know that what's happened is that there's a prioritization of people's health.
Yes.
That doesn't get extended to women because we've been primarily valued in every culture on earth for our ability to create human beings, which is tremendously powerful.
It's really kind of great, actually.
It's amazing,
Being
right?
pregnant is like an amazing, wild outer body
except
body experience.
Like, would I choose to have it be random who got pregnant when you had sex? That could be their best gender equalizer of all.
Yeah. No kidding, right? Mm-hmm. No kidding.
Everything would change.
Yeah. So like when it comes to the peri and menopause spectrum, continuum, what are some sort of like stats, facts around length of it? How long does this generally last? Is there, if we're going to generalize?
Yeah.
What can we think about?
I hate generalizing, but I will do my best to answer your question and tell you that most people who have ovaries experience a decline in their ovarian function that begins in their 30s and extends until they're in their mid-50s. And there's variability there.
Yeah.
So that decline is what we call perimenopause.
Right.
When that person no longer menstruates for a year, we define that very arbitrarily as menopause.
So like that's the period
we have a
at
point
the end
in time, just like menarche is the first onset of the menstrual cycle, but it's not actually the entire pubertal experience.
Not at all. We're feeling it.
But it's a good place to mark, right?
Yeah,
like I like having those markers.
Yes, I guess so, right?
And then the postmenopause, that lasts till you're dead.
It does.
Forever. Oh, and it doesn't get better. And unlike hot flashes, other effects of menopause, like bone loss and genital atrophy and cardiovascular disease and musculoskeletal changes. Did I say osteoporosis? No. All of those things, those all get worse with time.
I know that.
They don't just stop after a couple of years of sleep disruption.
God. I know. So the reason that we are raising this now and talking about it is so that we can all know ourselves better and know and understand this continuum and spectrum. I remember, again, tangential, I remember when I realized that life was made up of chapters. And it was when I sold the house that I raised my kids in. And my kids were like in college and on their way. Life changed, you know? I sold my house and I was like, oh, that was a chapter. Yeah. It wasn't everything. No. It was like that chapter, but you go into it thinking it's everything. And then when it's over, you're like, oh, it's over. Yeah. You know, so, but then you don't know what's next. It's an evolution, right? Just like this. Right. Just like this. So here we are in our 50s, let's call it, generalizing.
I like that. It's very generous. Yeah.
when the period stops.
Or we could just say after 50s.
After 50s, whatevs. And the period stops and we're now entering into this time where it's like, oh my God, now we have to work out all the time and build muscle mass and yada yada.
Basically decelerate the aging process so that we can live healthy lives. But I try to think of the positive side of this is that we are finally free of the tyranny of reproduction, right? That now we don't have to worry that when we have sex, we could get pregnant. And if we are pregnant, we may not have control over our health
anymore.
And that's pervasive throughout the world.
Yes.
It's not unique to the United States in this terrible moment in time. It's always been true for women throughout time.
We had a bubble, didn't we? We had a moment of a bubble of like, oh, I think maybe we're going to get to control stuff.
Yeah.
But wait,
moment.
You mentioned the sex thing. So like now we're finally free. Here's the rub.
Yeah.
We're finally free to go off and be the sexually active nymphs we wanted to be when we were younger, but we felt we couldn't. And yet we can't have sex because it hurts so much.
Oh, well, I'm so glad you brought that
Oh my
up.
God, it hurts so
because
much.
At least a third of women after menopause experience terrible pain with sexual activity.
Only a
particularly
third?
insertive sex.
Only a third.
At least a third is what I said. Because you know what's really interesting is that we're so used to women suffering, women too,
people don't talk
that in my very own gynecologic practice, I sometimes have to ask women many ways to get them to admit that they have pain.
Really?
Because women are comfortable saying things like dryness. Right? Because that doesn't sound like they're complaining too much, right?
Yeah. Because they don't want to complain.
Right. They don't want to complain. So
Oh
I may have to ask them several ways.
Yeah.
Or I may have to demonstrate that something hurts.
Ouch. It does.
But I think that women are often told by their doctors, by the culture, that this is normal.
Right.
That sex is painful.
I think that is what we're told. Yeah.
And that they should kind of tough it out, get some lubrication, drink some wine, use it or lose it. You know, that's just the way it is. Get used to it.
Right.
Like why women are ever endorsing this attitude that they should engage in something that's supposed to be pleasurable if it's hurting them.
Right.
And then we wonder why women don't want to have sex.
Yeah, I know. Okay, we're going off into a topic that I'm just going to say it. We're talking about menopause, but this is part of it too. You can still have an orgasm and not have sex.
Well, I don't think of sex as penis in the vagina. That's like that to me is one type of sex that has been over-valorized, of course, for obvious reasons, right? But of course, what I want to do as a sexual medicine doctor,
because that's part of your specialty.
Exactly,
talks on this kind of stuff too,
is
which is
to
really
clarify what is the patient's desire.
Exactly.
Right?
Yes.
It's not up to me to tell her what I think is the best kind of sex to have. It's to serve her needs.
Yeah.
Because people have sex for all kinds of reasons, right?
Yeah.
You and I might decide that our reasons are the reasons that are good reasons, but I'm going to treat the person in front of me.
Right.
And that's what you have to apply for everyone.
Yeah.
Right? That person might think that having intercourse, putting a penis in her vagina is super important.
For her partner, probably.
Or for herself.
Yes. Okay.
Right?
Okay.
Because
that it's validation.
People have sex for all kinds of reasons, right?
Yeah. Yep.
And as much as I would like to empower that person and educate that person about how pleasure could be centered in her life, pleasure is different things for different people.
It's true.
Right?
And at different times. It's
absolutely.
Yeah, I definitely feel that way.
It could be pleasing her partner.
Right.
It could be staying in a relationship. It could be providing a duty that she believes she has, right?
Okay.
It's not for me to decide.
Wait, when you just said that, you said those three things, literally 3 people popped into my brain that I know think about it those 3 different ways.
Right.
Yep.
Pleasure could mean freedom from violence.
Yes, that's
Pleasure could mean freedom from pregnancy.
Yep.
Pleasure could mean I don't have a duty net today because I let that person put a penis in my vagina and it's over.
Yep.
So I agree that educating patients about what sex is important.
Yeah.
But that doesn't mean that the patient won't look back at me and say, but I want to put a penis in my vagina.
Yeah.
So I say, okay, I can help
Let's
you
figure out how to do that.
I can figure it out. I can give you the hormones. I can train your pelvis. I can give you the meds you need. I can do all the things that you want to achieve.
Right.
I can't change the world and the circumstances that you have that exist that have brought you to me with this particular desire.
No.
But I could also educate you.
You can educate and just help figure out a way to do it.
Right.
And that's, again, what we're talking about here. That's it. It's like that simple. It's so personal to just say, all right, all I can manage and think about is this. Each one of us, right? Like that's it. It begins and ends right here. So know as much as you can, right?
Right.
And like going back to a couple of things we talked about where you said, when you go in and talk to your doctor, know yourself, know your stats. Don't be like when your doctor says, when was your last period? Don't look it up. Like, know the answer.
Yes.
Don't
Because
waste time.
We all, exactly.
Right?
We all really want to make the most of our visits with our healthcare providers by being prepared. That's the single most important thing that I would tell people to do when they go to their doctor is be prepared.
Yeah.
It allows us to do a good job for you.
Yeah.
I say so many times to my patients, if we spend all of our time looking in your phone, calling your other doctor's office, I said, how can I possibly give you good care? I want to use our time together. Give me some information to work with.
Right.
And so this is what we want to tell your listeners, right?
Yes.
Be prepared, bring in your complaint, make sure that when the doctor walks in and says, how are you doing? You don't say, fine.
Don't
say,
use that word.
This is what I want to do today.
Right.
This is what I want to know.
I'm here to accomplish, right?
This is my most bothersome symptom.
Yes.
Can you help me?
Right.
And I would say to healthcare providers, if she gives you her most bothersome symptom and you don't know, don't diminish, don't negate, don't blow it over and say, where are you going on vacation? Say, okay, because people do that when they don't know. Say, I'm not sure I'm the best person to help you. Let me figure out who is and get back to you.
Yeah, exactly.
This is how I'm going to acknowledge your distress. I'm going to justify it, right?
Right.
And I'm going to reinforce the concept that I'm your healthcare provider and that I'm going to provide you the care that you need, right?
Yes.
And that could be with sexual pain. It could be with cancer treatment. It could be with a screening test. It could be just even acknowledging, I'm sorry you're suffering. It's okay to say you don't know.
Right.
I always say to trainees and students, like, the good doctor is the one who's acknowledging what he or she doesn't know and figuring out why.
Yes, because we all present differently. Like you said before, this period of time, which I'm loving this conversation because it's, saying, all right, there's this period of time when we're in this peri and menopause and andropause, which I want to go back to. But then there's the time after, which is like we're settling into this third of life.
Yes.
And we are all better equipped as people, women, everything, because we're older, we know more, we give less of a shit about anything, and we can focus on like, oh, I'm actually going to think about how I feel. I'm actually going to be aware of how I feel and then be able to go to a valuable doctor and say, okay, what do I need to do here? Right.
So there are many layers of how to fix this, right? Many layers of how to educate people. So yes, you need to be prepared for your visit. You need to know how your medications might be affecting your sexual health. Right. A lot of what I do as a sexual medicine doctor is de-prescribe and try to figure out what's causing all of this together, right? What's making you feel like sex isn't good or it's painful? Like what can we add? What can we take away?
Right.
And helping the patient figure that out because she's going to tell me the sequence of events.
Good.
Right. So really spending time with a nuanced history is really key. You mentioned to me earlier that you asked what hormone level should people get?
Yeah.
And I said to you, there's almost no situation where with a postmenopausal woman, or frankly, even a perimenopausal woman most of the time, where her hormone levels tell me something that I can't figure out from speaking to her. That's right.
But see, okay, then I'm going to underscore the importance for all of us to find a great doctor. And, really, to find somebody as we venture into this phase of life and then its continuum, we need to be talking to somebody who comes from the mindset of understanding menopause, andropause, like all of these things,
and
right?
It's difficult. And I think it's super hard for other healthcare providers because many of us are working within systems that don't support this kind of nuanced care.
Yeah.
I have colleagues who are very well trained, very smart, very well intentioned, and they're expected to provide this kind of care in a 6-minute visit and do a pap smear and order all the screenings that they're supposed to do.
Yeah.
Like I told you, everything not male gets siloed into our basket.
It does, though.
We can't possibly do it all.
There's no way.
So who would try to open a conversation that's nuanced about menopause, which takes time, or God forbid, sexual education?
I know.
This takes time.
Yeah.
And frankly, I think our healthcare system doesn't value it
No.
because once we're done reproducing, most of the culture doesn't really care what happens to us.
Right.
In fact, if we don't have sex, it would be easier.
Wait, and so then, frankly, this is when we're our most productive, I want to say, is when
We
we really could be.
Yeah.
Yes.
Because our care burden is reduced.
Yes.
We're not busy getting pregnant or trying to avoid pregnancy.
Yeah.
We actually could be really useful if we were
Heart's
hormonally
energy.
replete.
Yes. Hormonally replete. I love that.
Yeah.
No, it's true. That's really right on. I love it. What else do we need to know about? Oh, no, I want to go back to androgens.
Okay.
I want to go back to androgens. And
That's one of my favorite topics.
I know. I feel like we need to get deeper into what androgens are.
We sure do.
So can you just explain what the androgen is and why is it the stepchild?
Well, it's interesting. I mean, ultimately, I think that the neglect of androgens in women is due to a concept that there is a complete gender binary that is culturally endorsed, right? And then if we just say estrogens are for women and androgens are for men, then we don't have to actually do any more investigation.
Is that what is sort of like said is androgens are
Yes,
men?
I hear all the time that estrogens are female hormones, androgens are male hormones. You'll hear it every day.
Okay.
Right?
Yeah.
But what's more nuanced is the understanding that all of these hormones exist in all bodies.
Got it.
And they have different effects in different bodies.
Right.
Right? So there's different tissues throughout your body that have receptors for androgens and estrogens, and those receptors carry out different functions. Hormones are just chemical messengers. They're produced by glands in your body to send messages to other parts of your body.
Okay.
And so we all have all of these hormones in different levels. Women have more androgens, more testosterone than they do estrogen.
No way.
So why do
What?
men get androgens and we don't get them?
Is that true?
Of course,
Women-
except in pregnancy and ovulation, women have a peak of estrogen above testosterone.
That's
Most people don't know that.
So there weren't, and so there really just haven't been studies on androgens in women.
Right. Because if women could control their health and control their sexuality, then they would have a lot of power.
Yeah. Well.
And I think that it messes with people's ideas of gender if we acknowledge that all humans have all of these hormones.
Yeah, we're similar in that way.
And then there's that all hormone default hypothesis.
What's that?
I call it the hormone default hypothesis. I just made that up.
Oh, I love it, though. It sounds good.
Everything not male is explained by female hormones.
Just
right? Everything we don't understand about women, it's hormones.
It's hormones.
Right?
Everything.
Yeah. I remember sitting in medical school and hearing that men have
At Harvard, by the way.
cyclicity of hormones every day, like that their hormones like cycle every day the way we cycle all month.
Yeah.
And I said that to somebody and she's like, oh, is that why they're so difficult to deal with? Because they're cycling all day long?
All day long, they're just,
right?
It's
and
hormones.
I thought it was such a funny thing that she said that because, of course, we think of that as normal instead of what we're cycling over a month.
Right.
But then, of course, when we're postmenopausal and we're not making eggs anymore, then we're not really cycling. We're pretty steady.
Yeah, we are.
And in fact, some women who are very vulnerable to hormonally sensitive depression or mood disorders find that menopause is a time when they're actually feeling better.
Interesting.
Particularly if they're hormonally replete. Because if I give a woman a steady state estrogen and level with a patch, and there are no testosterone patches, unfortunately, here in the States, but there are some in Australia.
Are there? Oh, because they're doing tests.
So if I were a doctor in Australia, which is a pretty civilized country, and I was giving my patient a testosterone patch and some estrogen, and she had a nice steady state all the time, if she has a history of cycling mood disorder, she might actually feel much better.
Oh my God. Wow.
Yeah, there's some interesting researchers in Australia who are working on mood and cognition and testosterone.
Really?
Mm-hmm.
In women?
Yeah. In women.
Wow.
Yeah.
Wait, I want a life do-over and I want to live in Australia.
Well, I mean, that's one place that we could go right now, actually, that might be a little bit safer.
It might be.
Yeah, but I would say that what we want to do probably, since we're here and we're invested in being here, is not give in, right?
No, we're not giving in.
Not capitulate.
We're not capitulating.
Make sure that we're going to keep talking about these issues and not negate the experiences that women have here. Like this is a country that has not been developing consistently in a positive direction.
Right.
So we want to make sure that we're not silenced.
No.
That we talk to people about their health, their sexual health, their reproductive health, and that we not assume that we can't actually move forward anymore.
We can move forward.
Yeah.
We have to move
I
forward.
think we can.
And you know what, frankly, this is what this is all about.
Yeah.
It's about information.
It is.
Because you get information and understanding and recognizing
Right.
you're in charge of this,
Right.
this. That's
Right.
it. And know what you need to know and find the right people to
Right.
help you.
Right.
That's what it is.
I think that, right now our country is getting a really brutal seminar in obstetrical complications.
Yeah, sure.
And they're learning so much about the things that we as obstetricians have known for decades.
Yep.
That pregnancy is a life-threatening event.
Yeah, it is.
And that understanding is creating a great opportunity for all of us as doctors and healthcare educators like you to really get this information out to people so that they understand that when you make a healthcare ban of any kind, whether it was a ban on hormone therapy, a ban on evidence-based pregnancy care, a ban on certain prescriptions, or even a black box warning, which the FDA endorses, like that's government-endorsed medical misinformation,
Yes.
that this harms us and makes us less healthy.
Yeah.
And we shouldn't accept that.
We shouldn't. Oh my gosh. Okay. So that is a great segue too, I'm going to say, because have spoken about so many things. And I literally could sit here and talk to you for hours and
let's
go
do
deeper.
that.
Let's do it again. We're going to
It's
come back
Friday.
and we're going to talk. I know. It's Friday. We're going to talk again about
Okay.
more topics that have come up in my brain and I know yours. But we're going to wrap this up
Okay.
with 3 things that
Okay.
you would want people to take away from this, just top line things that should be on her mind.
Okay.
And you just said medical misinformation. That was your
Yes.
number 1. That was your
Yes.
first one.
Well, it's pervasive everywhere,
Okay.
right? So we want to combat medical misinformation.
Yep.
We want to call it out when we see it.
Yep.
And we want to make sure that everyone is invested in that.
Right.
That sometimes misinformation isn't always deliberate. It's literally due to a gender gap of data.
It's
right?
just we don't have the
Right?
information. It
I mean,
doesn't
there are
exist.
well-intentioned people that
Right.
actually give medical misinformation,
Sure.
like websites of hospitals that want
Right.
to inform people, but they've got misinformation.
Sort of like the whole thing that hormone replacement therapy is bad for you.
Right.
Right. Which is
Right.
literally not true.
No,
there
it's
it
totally
has
not
been
true.
debunked. It
Right.
is
It's good for you.
It's good for you.
Let's make it very
Right,
clear.
let's make it
Hormones
clear.
are good for you. And that's
That-
actually my second point,
Okay,
right?
good. Oh,
That
yeah.
hormones are not dangerous.
No.
But that doesn't mean that they're safe.
Right.
They need to be used with expert opinion, I should say, right? They need to
Yeah.
be used carefully because they do have effects. So you need to be clear
Mm-hmm.
that those effects are going to be positive for most people, but could be negative for other people. So
Right.
you need to use them carefully. And that means you don't want to necessarily get your hormones online from a longevity clinic that hasn't ever laid eyes upon you.
No, it's just like don't get your Botox at a wine party. Same kind of thing. Don't do it. No, because also what we learned here today
Yeah.
is that there are different kinds of hormones
Right.
and there are different ways of taking it. And if
Right.
you take it orally versus transdermally,
Right.
it might work or not work.
Right.
And that's a big deal. Like that's new. That's news.
And the subtext of this, because I don't know, I don't want to run out of 3,
No.
is that androgens are not male hormones.
That's your
Androgens
third.
are
Yes.
female hormones.
Yep.
They're human hormones. They exist in all genders, and that androgens control sexual behavior, I should say regulate sexual behavior in all mammals,
Okay.
right? So why would we think that human females would be different and don't need it?
Yeah.
What's amazing to me is the work that is starting to be done that shows that androgens are not just about sexual behavior.
No.
Androgens are also about health,
See,
bone health, cardiovascular health, brain health.
we need all of that
Right.
big time because that's
So
where we get
that's
impacted.
I would say to any young person who wants to do research, do some research on androgens in women.
Yep.
Because there's a great need for you. And then I guess the final one is really just try to imagine a world where women actually get what they need. What they need,
Mhm. Yeah.
right?
Yes.
Not what you're willing to give them as a last resort, but actually ask women, what do you need?
Yep. Yeah.
And provide it.
Yes.
Because if we did that as a country, first of all, it's very cheap to provide the kind of care I'm talking about. And an investment in the kind of care that I'm discussing has long-term benefits. Because not only if we invest in preconceptional care and contraceptive care, for every $1 we invest, we save at least $15. That doesn't even include the post-pregnancy complications that we actually prevent.
Yeah.
It's very, very clear that investment is good for the entire society. But we also could demonstrate that if we actually give women hormones preventatively, meaning don't wait for women to suffer to provide them, tell women that if they survive childbirth and go through menopause, they deserve therapy.
You deserve therapy.
Right?
Hormones. Yes.
And if you provide it, because it's cheap, right? It's like we use all kinds of medication for people that are so expensive.
I know.
Hormones are cheap.
All right.
Right? They're really easy to provide and they prevent disease. So save money for everyone. We have to talk about money in this country because it's completely based on capitalism, right? It saves money. This is an economic issue. This is not a women's issue.
No,
this
that's another topic.
Economic
That'll
issue.
be our next topic.
Okay, as well as a health and well-being and quality of life issue.
Yes.
But let's talk to the people that control everything. This is a economic issue.
Let's do it. I don't know how to thank you.
Oh,
this has been eye-opening, helpful, and just really great to spend time.
Oh, and it's so great to spend time with you too. Thanks for inviting me.
Yeah, we'll be back.
I'll come back anytime.
All right.
Thank you.
Thank you so much for listening to this episode of Inside the Wellspace. Subscribe now on Apple Podcasts, Spotify, YouTube, or wherever you listen to your podcasts.